Good morning. My name is Patty Michelle, and I am the Executive Vice President of the Personal Connected Health Alliance. I am extremely pleased to introduce our closing keynote presenters, who will speak about the importance of open data and the valuable clinical, social, and business opportunities represented by the release of health data sets made available by the Department of Health and Human Services. They will also engage in a discussion that addresses the tension and delicate balance between information, privacy, and transparency, a foremost topic in our civil discourse today, and an especially important conversation in an increasingly technology-driven health system. Susannah Fox is Chief Technology Officer of the Department of Health and Human Services. She most recently served as the entrepreneur in residence at the Robert Wood Johnson Foundation and has been an advisor to organizations like the Collaborative Chronic Care Network, working to improve care delivery by including patients in their innovation teams. Previously, Susannah was an associate director of the Internet Project at the Pew Research Center, where she helped quantify and explain the social impact of the internet. She was also one of the first, and perhaps even the first person, to apply participatory research methods to explore the impact of information technology and social media on the healthcare industry and the consumer health care experience, with a focus on people living with chronic and rare conditions. I have long admired Susannah's pioneering efforts in exploring how the natural progression of technology in the general population was being used to access health services and information. I've also had the privilege of sharing a stage with her. Fred Trotter is a healthcare data journalist, author, and technology entrepreneur. Among the companies he has founded is CareSet Systems, which creates a comprehensive map of the healthcare system by showing how healthcare providers collaborate to deliver healthcare. Fred is a technical blogger for O'Reilly Radar and co-author of the first Health IT O'Reilly book, Hacking Healthcare. He also currently serves on the Consumer Technology Work Group for the Health IT Standards Committee, which advises the Office of the National Coordinator for Health IT. Please give them a warm welcome, Susannah Fox and Fred Trotter.
Thank you. Hey, everybody. Hi. So indeed, I am the Chief Technology Officer at HHS, and what that really means is that I am the Chief Innovation Officer. The HHS Idea Lab is an incubator within this huge federal agency because we want to maintain a startup atmosphere, even as we try and execute against this very, very ambitious agenda. We draw people into the Idea Lab from all across the agency in order that we can create an atmosphere of creativity and entrepreneurship. And actually, IDEA is one of our famous government acronyms. IDEA stands for Innovation, Design, Entrepreneurship, and Action. And it was actually the vision of my predecessor as CTO, Brian Civic, and it's really an honor to carry that forward. The HHS Idea Lab has played a leadership role within the department and within the federal government in the data liberation movement. And what we're going to try to do today is tell you a little bit about what we in the US government have put online, and then Fred is going to help us figure out why is it useful. So for those of you who know us, I'm of course going to play the straight man, and Fred is not. And we came up with this idea because we really want, as we are frankly facing, you could call it an exciting time in healthcare. You might also say that it's an interesting time, to go along with that proverb that may you live in interesting times. And we really believe that we have a vision of a healthcare system where data is driving change. And there are so many changes happening that it would be understandable if we focused on the trees, if we focused on the things that all of us are trying to execute against every day, whether you're worried about the next funding round, whether you're worried about the app that you're trying to build, the memo that you're trying to write, whatever it is that you're doing, you might lose sight of the forest. And what I wanted to take a moment to step back and say, the forest in this case is that we really are changing the American healthcare system. And I believe that we're changing it for the better. But the only way that we're going to be able to tell that the interventions that we're all trying to do are going to be working is if we have data, if we're able to take the temperature of the patient as we go along. And that's what we're able to do with data. So healthcare is indeed an incredibly complex system. And we're undergoing rapid change in payment models. And everyone at every level is looking for a framework for decision making. And what we wanted to do today is present to you a way that you can help decision makers see patterns in the landscape through data. That's the opportunity that we see, and Fred is going to talk more about that in a few minutes. What we see is a view of healthcare that's coming into focus thanks to actions taken by administrative leaders who set the open data revolution in motion. And I want to tell you that sometimes I joke that I feel like I'm an exchange student to government, where I had to learn this new language of acronyms and had to learn a new culture. And one of the things that I recently realized is that one of the, probably one of the signature achievements of my time as CTO is something that I actually wouldn't necessarily be able to even explain to my mom or my friends. And that is, I wrote a memo. But it was a really good memo, and it went to the right people. And an example of a powerful memo is this memo that was released 3 years ago last week by John Holdren. And what he was able to do was direct large federal agencies to develop plans for increasing public access to the results of research that they support, and specifically scholarly publications and digital data. At HHS, we had been opening data sets for years and took this directive as an opportunity to expand our data liberation movement to include not only care delivery data, but also comparative effectiveness, emergency preparedness, public health, environmental health, and toxicology research data. And if that sounds like a very broad portfolio for a single federal agency, it is. Because HHS is one of the largest federal agencies. We have about 90,000 employees, and it's divided into 11 operating divisions, which you can see on the slide. And each one of these operating divisions collects and uses data, and you can in fact see what we collect and what we make public on a site that my office created and oversees called healthdata.gov. It is a one-stop shop for data that can start to help you see patterns in the landscape. From the very beginning of our open data initiatives, entrepreneurs were a primary audience for us. And that's thanks to the vision of Todd Park, who was the first CTO at HHS. We believe that by growing the number of people who can contribute to the healthcare marketplace, the better off we will be as a country. So I'm just going to highlight data that's come from 2 of our operating divisions as examples, just to give you some context and scope for the role of data at HHS. First, I'm going to talk about FDA. A team at the Food and Drug Administration has been working to not only liberate more data, but to make the data available in more useful formats via API and raw structured file download. They're doing this through the Open FDA project, which provides easy access to the many large and important health data sets collected by the FDA. Again, when I came into the federal government, I knew that there were quite a few different ways that the government was tracking data, and even just within the FDA, I hadn't really realized the scope of it. Examples of the types of data that are now becoming available include adverse event and medication error reports about drugs and therapeutic biological products, recall data, which includes food, drug, medical devices, cosmetics, biologics, and pet food, which is really important. Structured, as a new dog owner, I think it's very important. Structured product labeling data. This information includes data that's on drug labels, which can be really powerful if you think about how you can create a searchable database, for example, of the data. I'm particularly intrigued these days by the hardware of healthcare, medical and assistive devices, and how that landscape is going to change as 3D printers and other manufacturing tools become more widely available. So I was really glad to see the expansion of OpenFDA's release of medical device data. Data collected since 1976 on device pre-market approval clearances is now available. In addition, more details about device recalls, including 9,500 records going back to 2002, and adverse event reports, 4.2 million records since 1991 were added. And although information has been available publicly before, it's now more easily accessible so that people can really use the data. Turning to CMS, what we find is that the Centers for Medicare and Medicaid Service really shows that we are living in exciting times with more change on the horizon. And through all this change, everyone in healthcare is searching, but so that they can change patterns for the better. The data that's now available allows people to view population health as not only vital to their own hospital or healthcare system, but for their zip code or region. And that's incredibly powerful information, especially for an entrepreneur. An open question, and one that's worth pursuing for economic reasons and for human benefits, is how can we start to understand the disparity in health outcomes across populations and across costs for care? How might we move the needle on these questions? I would argue that data is the key component to any solution that we try. Since health delivery system reform is so much at the center of what we're talking about, I thought I'd take a moment to talk about our 3 areas of focus. The first area of focus relates to paying providers. We want to promote value-based payment systems, and Fred is going to talk about how we're moving there. We're in fact adding that in. We're adding the value-based payment models onto the system that we already have. We're going to try and increase the linkage of Medicaid, Medicare fee-for-service, and other payments to value. We want to bring proven payment models to scale. The second area of focus is in care delivery. We want to encourage the integration and coordination of clinical care services, improve population health, and promote patient engagement through shared decision-making. And third, we want to distribute the information. We want to create transparency on cost and quality information and bring electronic health information to the point of care. Now, the next slide shows where we are and where we are heading. CMS is at the forefront of a nationwide effort to transform healthcare delivery, calling on all of us to place empowered and engaged individuals at the center. The patient-centered care approach considers the person as a multifaceted individual, not merely a carrier of a particular symptom or illness. Data liquidity is an essential component of this vision, and interoperability of health records is the mechanism by which we will see that happen. So in closing my section of this keynote, I'll note that we in the HHS Idea Lab very much value you, the entrepreneurs and innovators in this space. And we invite you to consider how you might take advantage of all that we offer, the open data that we're talking about here today, but also opportunities to actually come and work for us. I can tell you that I have learned so much about the healthcare system by actually spending some time inside the federal government. And what we do is we allow for people to take a tour of duty within the government as an entrepreneur in residence for a year or an innovator in residence for 2 years. We're actually going to announce in a couple weeks a new opportunity that's really right up the alley of anybody who attends HIMSS. And it's going to be related to the Medicaid marketplace. We're going to be looking for a technology entrepreneur, somebody who's had startup experience, to come and help us with the Medicaid marketplace. So please stay tuned, follow HHS Idea Lab on Twitter. And also, if this stuff is of interest to you, I would say that you should also check out and come to DC in May for the Health Data Palooza, where you essentially meet everybody who, like us, are health data geeks, and we see the possibility in the data that we share. So now it is my great pleasure.
Okay, so thank you for having me. I'm a data journalist. I spend my time either trying to convince the federal government to release more data with DocRaf or organizing it, which is CareSet. For this talk, we're going to be talking mostly about CareSet stuff because in general it's the organization that adds the value. So this is the data set that I'm famous for. You can download it and there's a link. I'm tweeting these slides so you can get this link. This shows how physicians work together. And I'm going to hopefully, before I'm done talking, show you how that can be turned into this. Notice that this is a risk board with pieces on it, which is to say that you can see the strategic landscape. You can see both what's underneath the board and also what the other players are doing. So this is a basketball court. It was the very first basketball court. This is the one that was invented probably almost 100 years ago. At that time, a team size for basketball could be anywhere from 9 players to 50. You'll note the baskets are right up against the wall, so a good strategy was to run up the wall to do a layup. You also could identify who your free thrower was. I should back up. I'm going to be using sports analogies, and I apologize for that. So moving on. You could designate anyone as a free thrower. Anyone could shoot, so you had specialized free throwers. Very quickly that changed. And we started to get more and more specific, more and more detailed, more and more controlled rules meant to curtail certain strategies. So for instance, twice there was a center post who was so much larger and physically domineering than everyone else in the league that they had changed the layout of the court to accommodate the other players, so they would not be able to basically stand in front of the basket and just swat everyone else down. And that was for George Mikan and Wilt Chamberlain. Now, what I want you to see from this is that over time the rules changed, and as the rules changed, different strategies were working for basketball. Which is basically the point at which the sports analogy stops being useful. There's a tremendous number of rules, and in a certain sense there is an artificiality to this industry because of the number of rules in it, and it's competitive. But as those rules shift, we get a new winning strategy. So as we talk about healthcare reform, reform really is the right word. We are reforming everything from scratch. The old rules do not apply, except to the sense that they do. And I think the biggest single change is that healthcare is becoming a team sport. There were teams before, but it was basically reputation. So in the same way where you have a golf team, which is to say you go to play golf with a bunch of people, it's still an individual sport, right? The incentives previously were geared towards individuals, and you could maximize your individual payment precisely by ignoring how the rest of your team was doing. That's not going to work anymore. When we add value-based care, when we transition to value-based care, it's a team sport. And one of the things that I wanted to point out here is I don't actually know what that means. I would also like to point out that no one else does. So people who tell you, oh, well, I know how value-based change is going to change the structure of healthcare. I study this all the time. I'm quite confident that I can tell you that is not known and not knowable. But we can talk a little bit about, so Jonathan Bush actually pointed these competitive forces out. I wrote a book on how those impact health IT. You should buy both books, his first. Mine will be a waste of time if you don't agree with what he says. So let's talk about this platonic ideal a little bit. This is a picture of the kind of model in our heads that we have for healthcare. You have a primary care at the center. A patient starts at the bottom there with healthy at home. Then they go to the primary care and they get kind of shuttled around in a pattern that looks like a flower. Hopefully they don't have to go to the hospital. If they do, they go into what looks like a waterfall of post-acute care. Now as we look at that, we can change that same diagram and start showing the edges and the connections that are not okay. So one of these we know as readmissions, and we have a very specific disincentive. I submit to you that all of these red arrows, which is to say going back up the post-acute waterfall, will eventually be verboten, and I think there's probably other ones that we just don't know about and we don't know where they are. So that's what we think it looks like. Let me show you what it actually looks like. So if I can take a second and switch to, this is what the actual data looks like. So it's a 4 gigabyte text file that you could download. If you want to do a word count on it, there's 90 million rows of data. And if we want to look for a little bit of data, this is my physician, his NPI number, and I'm just going to grep that file for him. And now you're seeing all of the data that I'm going to display, basically, during this talk is based on this single data file. There's a bunch more data files, but I'm just talking about this. All it shows is how patients flow from provider to provider using NPIs. Going back, the first improvement we make, right, as we think about how this should work is, wouldn't it be nice to think about those things not in terms of numbers, but just with names, right? So many of you will be able to answer significant insight questions by just downloading this data, running a grep, and then moving on with your life, right? A week-long analysis that really helps your efforts. Others of you will actually do many of the things that we've done here and go a lot farther. But the first useful thing to do is just to be able to see, well, here's a doctor, and this is the type of doctor they are, and I'm going to link over, and now I can, if I wanted to, I could click and see their referral patterns or their teaming arrangements. But see, this is the problem, is that this is not a data set that is tabular in nature. This is how my doctor actually teams across all different types of physicians. He's the big guy in the center, the little big bubble there, and you see that there's a little cluster where there's a massive amount of patient flow, so the edges here, thick edges means patients moving a lot, where the people that he teams with are also teaming with each other. And then you also see that in many cases, he's working with physicians who don't team at all. So immediately we see that our kind of platonic ideal is very far off. The problem with these kinds of things is that it rapidly becomes impossible to start seeing what's going on. That is what Houston looks like. Moving right along, that's an ACO. That's an ACO and how they relate to a single type of doctor. So the orange doctors are the specialists, and the blue dots are the doctors inside. Now we could do an analysis over time about how things change, but that's too many doctors to do that, so I'm just going to do that with 10 doctors. Now I'm going to show you in 2009, 2010, 2011. Now an ACO is supposed to narrow networks. Is that going to happen? After a while, you start to see the specialist count in the center is going down, right? So you see the narrowing of networks. All of this is based on the same raw data that I've just shown. And there's the last picture, I think. All right. Now, what if we take two data sets, the prescribing data set and the referral data set, and put them together? Now what I'm showing you is a team of doctors who refer together, who work together, team on the same patients, and how they share medications. If you study this carefully, you'll see that cardiologists and primary care doctors are treating the same things based on their medications, which is a trend that we already knew about. Now you can see, and this is the kind of data that we are only now getting out of ERDC, how zip codes work with a particular group of doctors. So this zip code is feeding patients to a particular provider. So you know that, again, the same small group of doctors, you can see where their patients come from. Again, all based on either open data or data that will be open soonishly. Real soon now, trademark. Now we do have a few things in CareSys data that are not fully open, but for the most part, there's a tremendous amount of data and value that you can get. So because of open data, we can see what's happened, we can see the landscape, we can see what's going on around you. If you don't look at this, what you're in the position of asking to a healthcare reform is, what should we do? And that's the wrong question. The real question is, who should be doing it? Right? How should the overall structure change? How should the team change? So, the only other outside sports analogy that I could come up with was how broadband internet changed the landscape for Blockbuster. Blockbuster literally laughed at Netflix when Netflix proposed that they should be acquired by Blockbuster. Ha 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 ha. They had a meeting. They laughed, right? And Blockbuster didn't understand until it was too late that not only were they not being an effective competitor, they were competing in the wrong space, that their whole space was irrelevant. I think that's a good analogy for the kind of old school thinking and the shift to value-based care, which brings me to this slide, right? In risk is a wonderful analogy because if you've ever played Risk before, you know that you have to pay attention to what's about to happen with the other players, and if you don't, you'll be flooded off the board. So you playing Risk where you don't see your competitors versus you playing Risk where you do is the difference between survival and not survival, which I think is a fairly good position to indicate where we are. So HHS changes all the rules, changes everything, and will put people out of business. But at the same time, they are releasing a treasure trove of data to give marketplace participants the insights that they need to not go out of business, which is, I think we can do questions now.
And I forgot to say at the beginning that we're going to take questions, of course, from the audience, but if there are people who are following along on Twitter, we're also going to, and if people have questions, you can also tweet them at the hashtag, and those are going to pop up on our monitors as well. I have to say, I love it every time we give a talk because nowadays you sort of gesture at me and say, HHS. And luckily, I don't actually get involved in changing the rules. I have the fun job of being able to say.
You do represent HHS.
So today I represent HHS, but the idea is that I represent the part of HHS that indeed wants to help entrepreneurs and wants to help people by freeing the data.
How many times have you had the conversation with me where you say, Fred, you're vastly overestimating the power that I have in the job, and you can't get that. I think on a regular basis, we've been friends for a long time because we care about the same thing. We have a shared passion for data, which naturally brought us together, which we've known each other for a long time. And I call her and I say, HHS should, followed by something that probably the president couldn't pull off, and then I just look at her.
Right.
Like, that's a good idea, right, though?
So if you guys have questions for me or for Fred, come up to the mic, and if there are questions on Twitter, I'd also be happy to see those. In the meantime,
I have a question.
I have a question for you.
Oh,
But,
rock, paper, scissors?
Okay, you go ahead.
Right. No, we're
Okay, rock, paper, scissors, ready? 1, 2, 3.
No, that's not good. Okay, go ahead.
So if you were going to open up a next data set, what data set would it be? What do you think is missing right now? And by the way, it's not just at HHS, but any data set, because we were talking backstage about how one of the challenges with the data that we provide is that it's Medicare beneficiary data. And so I'd love to hear what you think about.
So you know that, I want to make a request in front of everyone. Please open up Medicaid and Medicare Advantage. This is another one of those things that's a big ask, but we're losing control. Medicare is the best picture of healthcare that we have. It's huge. Medicare Advantage is slowly eating away at it, which is good, right? Medicare Advantage theoretically is a good thing, but we don't have that data. We don't see that, so we're losing information every year. That's a problem. We also don't know enough about baby doctors and mommy doctors, and that's in Medicaid. I would love to go to every commercial claims vendor and say, this is not for you, this claims data. You have an ethical obligation. I've actually thought about sending them FOIA requests and saying at the top, I know you're not legally obligated to answer this FOIA request, but shouldn't you be? And seeing how they reacted. And they'll ignore me.
So that's a question I'd love to hear from people. Oh, we have a question. So while we're listening to this question, think about if you could wave a magic wand, what is the data that we really need in the space, whether it's from HHS or elsewhere? So please, if you don't mind introducing yourself.
Hi, Paul Groth, Elsevier. I just had a question about using some of this open data. So it looked like that data had some personally identifiable information.
It absolutely has personal information about providers.
Let him finish.
Just what is kind of the process?
You have to let him finish. I don't have to let him finish.
Please go ahead.
What's just the process for getting a hold of that data? It's clearly not just go download it somewhere.
It is, because it is personally identifiable, but not at the patient level. Almost everything we do is identifiable at the provider level. There was a huge court case at a previous time, even providers had protection. That's bullshit, and so we stopped doing that. So I really appreciate, thank you for that. I don't know that you did that one, but so essentially, in my mind, a doctor who bills Medicare is not different from Northrop Grumman or Boeing or any other government contractor, and they don't have privacy about how good of a job they do. Now, they convinced a federal judge in 1982 or something that they did have that privacy, but that was overturned, which means we have this wealth of information that is coming out in the last 2 years about provider-level documentation. We've actually known a lot of information about what happens in hospitals for a long time, but there has been a revolution in provider analysis because of that.
But that's a great question because it points out that PII doesn't apply to the providers. So
Yeah.
thank you.
And they are very careful about that. HHS is extraordinarily careful about making sure that things you get to know about providers don't allow you to infer things about patients.
Yep. Please.
Hi, I'm Brian Clancy. I'm with IMS Health. Susannah, you mentioned the patient-centered approach that HHS has. Yesterday, Karen and Andy, they talked about their cloud on fire, right? And they talked about some new grants opening up for a discovery portal for finding apps that leverage these new APIs and pull data out of EMRs. Any perspective from your approach as, you know, an innovation lead on, you know, what the vision is here for that type of thing, and, you know, maybe what types of proposals would make people really happy?
So I was thrilled when they were able to allocate the money to create this portal. And what I was especially thrilled by is that it's going to be an outside portal. It's not something that the government is saying, you know, we don't take the approach that we should make all the rules. We want there to be a portal. And so we're sort of putting up guardrails. The role of government, as I see it, is to put up guardrails as something around things that the private sector should do. The private sector should create more apps that allow people to get control. Data should be liquid. Data should be interoperable. Data should flow to the patient and caregiver level so that they can then direct it. And so one of the programs in my office, Mark Scrimshire is an entrepreneur in residence who's working at CMS to create Blue Button on Fire, because we believe that the Blue Button data should flow to the Medicare beneficiary and then flow to whatever app they want to. And so by creating a marketplace for apps, I think it's fantastic, and I was really glad to see the announcement. I'm also glad that we are not trying to take the approach of rating the apps ourselves, because I don't think that's not necessarily where we should be at this time.
Thanks.
It just makes me happy in general when the government says they're not going to do something.
It's cool. You should definitely take a look. I read the proposal. It's a really good proposal. Yes.
Hi, I'm Basa Chowdhury. I'm a primary care physician and a medical informaticist. I have a startup called Tupelo Health. My question follows up on a point Fred just made, and I'm really curious as to how HHS is thinking about data issues with respect to Medicare Advantage, one, and then two, Medicaid. Because outside of just technology issues from a policy perspective, I have a deep concern about this. So we do work across fee-for-service and MA. So we've spent time, it's just like a practical issue, we've built parsers to work with CCLF files and visualize the data. Every MA plan we have to work with is totally different. The data definitions are different, the way the data is managed and stored is different, the way it's updated is different, and that's for every single MA plan. And in addition, obviously, like Fred, when your work has obviously been terrific, but your data set isn't going to have a lot of insight into Puerto Rico, right? The concern is sort of the way when you look at new adoption of MA, particularly for new seniors, and in places like Puerto Rico or Florida, we don't really have a good sense of what's going on in those markets. And that's, I think a general concern. And from a practical standpoint, it makes it very difficult to actually work across Medicare populations. So I'm just curious what the thinking is for HHS with this issue.
So, unfortunately, I can't speak to that because I don't work at CMS.
But I'm a person who has no idea but is willing to speak. You have a great idea and are willing to speak, and that maybe we could meet in the middle.
So what I would say generally at HHS is what we're trying to do is create the environment that encourages everyone to use best practices in terms of data, in terms of the collection of data, and then the dissemination of the data. And so, yes, we have some work to do, particularly in Medicaid, and because the collection of data it's a patchwork. While not quite answering your question, I do want to say that other of my colleagues are here from CMS who might be able to, and thanks, because I can take that back. Fred is now going to answer the question, not on behalf of HHS.
Yes, very specifically, I do not speak for HHS. Having said that, HHS has demonstrated very clearly that they are committed to open data. So their heart is in the right place, and the things that they don't give me that I ask for and want, it's because they can't. It is not because they won't or they don't want to. It's because they can't. You know, you and a lot of other people I really like are not going to be employed at HHS for very much longer. I am very happy to say...
And that's because I'm a political appointee, not because... I should say I'm not going to get fired. But since I'm a political appointee, I leave when the president leaves.
Which is unfortunate. We should try, I mean, if we could keep you.
But the good work will continue.
The good work will continue precisely because I think at this point, the value from Medicare has made the value of open data to the ecosystem uncontroversial, right? So especially if you're a Republican coming in and you say, we want to really overhaul Obamacare, we want to change the rules yet again, the industry would demand even more open data, right? They'd be like, we really need this data now. And with Medicare, you've demonstrated it. I do think that the big decisions on Medicaid and Medicare Advantage are going to be dependent on that next cohort. But I'm very happy to say that despite the fact that all my friends are going to be, I think, happily retired probably, there's going to be new people who care about this too. The other thing I would say is, if you will comment on, when they ask for comments on something, it is not a fun process to comment on government stuff, but they actually listen. They really do, and you should participate in that. And so, especially a year from now, we need to have a chorus of people saying this open data stuff is good, do more. So you can help.
I've written comments before, and I know it's a wonderful process. So thank you for the opportunity, for the fun. We'll do it again. Thank you. It's just, this is a really pressing issue, so I appreciate your comments.
Great.
Thanks.
So we're going to take the next real person question, and then we have a Twitter question.
This is not, you can't call Twitter people not real people.
Well, she's sitting right there. So.
I know, but I mean, yeah, it doesn't work that way.
She's going to skip the line by tweeting. Please go ahead.
Hi, I'm Ed Bennett, and I'm with the University of Maryland Medical System for the next few weeks, and then I'm going to be a consultant. Hospitals are starting to place their HCAHPS comments and ratings on their physician profiles. They call it physician transparency. We're starting to see much more adoption of that. My question is, what are some of the insights that could be taken from this data that would help a patient in selecting a doctor, and what kind of value might help them in guiding that process? And do you see any way that we could integrate this data into the transparency efforts that are going on?
The stuff I'm going to say is more interesting. You can't say the interesting stuff on this.
Go for it.
Okay. So HCAHPS is just a huge issue for me as a data analyst, because I know that there's an undercurrent of pettiness that occurs from the patient. So I didn't like the fact that I didn't get the antibiotics I wanted, or maybe the narcotics that I wanted, and so your room wasn't clean, right? That element makes HCAHPS extraordinarily difficult to analyze, and makes that whole system, on the one hand, extraordinarily valuable, because before there was nothing. Right. I think it's marvelous that they're being transparent about it. And overall, this is a concern. How do you handle transparency when what you're showing is impossible to correctly interpret? We're extraordinarily conservative in what we will say. I'm recently divorced, and that means that I have a new profound humility about my failure to predict human behavior, right? So the notion that I can look at a data set and say, oh, I know what the patients are thinking, or I know what the doctors are thinking, it doesn't work that way. One of the things that I think, the trick that I have learned is successful is, there are truths in the data, profound truths in the data, that you can't argue with. You can't argue with the fact that those doctors are sharing patients. They are. Whether or not they're doing a good job or not, that's complicated. But they are sharing patients, right? And that is there's a fundamental trueness and a not fundamental trueness. So sorting out what is good and bad, HCAHPS is a really interesting place, because there's components of both in that survey. So does that not answer your question adequately?
Well, I was thinking more, acknowledging the issues with HCAHPS, I'm thinking more the data that you're pulling together. What sort of insights could come from the data you have that could be added to those profiles?
So, I mean, I think ProPublica's work to do surgeon scorecards is both, I can't endorse it because I don't really understand it well enough to know. I can't endorse what they did, but I can endorse them. Like they're a crack team, and I'm pretty sure they did something excellent. But that kind of thing, where you have a careful data science team coming out with scores that come from these kinds of data sets, adding them together, I think it's a super valuable approach. And more importantly, it's the one-eyed man in the line to the blind. Like blind. Is that right? Blind? Bland?
Blind.
No, blind. Yes. It's a little bit better.
And I'll just say, so the question, Mandy, is how do we encourage citizen scientists in mass market adoption consumption of the open data and resulting insights? And I think it dovetails with Ed's question because and we've talked about this because you came up with this great analogy of what does the government do in terms of releasing data? We provide the wheat and other people, and we also sometimes mill the data and provide the flour. So that other people can make muffins and cakes and pie crust and whatever you want to make with it. And what we're really excited about is when people like Fred or people like Charlie Ornstein at ProPublica or Thomas Getz at Iodine. There's so many people who are taking the data that we're releasing and making something special out of it. And what people can do is layer on top of that even better data than, let's say, the HCAHPS data, so that, how might we create a Yelp for providers? How might we create that same kind of thing, by the way, for all of the other aspects of HHS data that we release, including drugs, including devices, including food, all of this material, it's sort of raw material that we release, and then people can create what they would like out of it, and even say this data isn't useful. So, next question. Thanks.
Hey, my name is Ari Tulla from Better Doctor. So we were probably one of the first ones to take up and put the claims data, Medicare data onto our sites. We have about 20 million people who've been exposed to it, and a lot of learning. I'm happy to share those. So big thanks for you both on getting this done, because it really helped me and our company to build our vision. And now what we are actually working on, we have an API, so we put all the data you are providing into our API. We're providing to 500 people today, and we actually are now helping Yelp and others to do this. So I don't think there's a need to build the Yelp for healthcare, because there's already Yelp for Yelp. But my question is that we are now facing a big challenge on the quality of the basic attributes like name, phone, address. And we all know NPI is about 48% incorrect. We have data coming from multiple places, but we can't fix the basic data. So what are we doing this year? We're going to make probably 500,000 phone calls to doctors to validate information. And there are new laws, as you might know, in some states that we know we need to get the data approved and cleaned up. So that's something I would love to kind of understand. Are there any activities? PECOS came out now. So are there any other activities going on around getting the NPI data to be better?
I can tell you that there's progress, and it's woefully inadequate. That's a wonderful question for you.
And unfortunately,
he's asking about data quality. You have a beautiful Finnish accent. I love your accent. He's asking about data quality. Some of the data quality coming out of NPES, which is a foundational data set, is really crappy. In fact, they wrote an OIG report on how crappy it was just on addresses. Like, it's probably the only government reporting I've ever seen where it's just like, this data is crap. And that's all the report said. So this is one of those things that I'm going to look at you and be like, you can fix this, right?
Right, and I can't, but it's a good question, and
I do know they are working on it. They are working on it.
Yeah.
There are people whose job it is to fix that problem, and they avoid me at conferences like this.
So
I don't know.
I realize that I don't have a timepiece. So are we at time? Because it's.
Yeah, your clock is very complicated.
Oh, 5 minutes. Okay, great. Because it keeps counting down for us and flashing red at me. So I want to be mindful of people's lunch.
Yeah.
Okay, great.
5 more minutes.
Great, thank you. Obviously, your work is very important. I have a question, slightly different question. In talking to folks running Pioneer ACOs, one of the complaints they've had is getting data out of CMS that's timely and actionable, especially for managing leakage, figuring out how they're doing against their revenue targets, against their cost targets, and people running down the street to an expensive AMC and then, blowing up their budget. And the government is really encouraging people to take more risk with the Next Gen program, folks are doing that. Is there any light at the end of the tunnel in getting faster, more actionable data out of CMS in terms of being able to, manage those during the year as opposed to getting through it and then finding out, sorry, your budget's been blown up? And before I answer that question, I'd also share with you something on a slightly different topic about data, that the Supreme Court just came out with a decision that will blow up a lot of the all-payer claims databases run by the states. So hopefully the next administration will take that on as maybe some kind of federal protection for that kind of data collection, because that's where we're really getting a lot of insight into how the healthcare system is actually working, is at some of these state level initiatives. But I'd be curious about what CMS might be able to do to help the next gen organizations do a little better.
Thank you. And we're smiling at each other because he knows that I actually can't answer that question because I don't work at CMS. So I apologize. It's, again, a great question. If there was somebody from CMS here, they would be able to answer, but I can't.
So in the absence of a real answer, I will continue to spout opinion. So that SCOTUS case is extremely important. What it specifically said was ERISA-based employer insurance companies are no longer required, or you cannot legally require them to participate in state all-payer claims databases, which is a tragedy for open data because those all-payer claims databases was a huge step forward. The only silver lining, which you already pointed out, is that it might pave the way for a national all-payer claims database, because essentially SCOTUS says that is the only way you can legally do it now. I don't know if there's going to be political appetite for that, to be frank, but if there was, that would be cool. As far as the ACO goes, I mean, the magic of an ACO is that basically two things. One is that you get exclusion from the FTC, so you can get a group of doctors together and you're not subject to the same rules as far as competition goes, because you're doing it, you get some get out of jail free cards about stuff that would otherwise not be okay for competitiveness. If you are going to focus on accountability, and then the other magic thing is that you get data. And if that data is not great, or it's late, or it's wrong, or it's, that's a huge problem. And the only thing I can say is it's important for you to complain at every microphone at this conference, because the government does listen. They can't answer on stage, but if they get enough questions about the fact that CCLF data is crappy or problematic, they will do something about it. And there are people who are working on that problem too. I mean, our ACOs are kind of where we came from a CareSet perspective, is that we work with a lot of ACOs, so we have done a lot of CCLF analysis, and in fact, many of the things you just saw were lessons learned from thinking about the world from an ACO's perspective. So my heart goes out to you, and I'm sorry I don't have a better answer.
Hi, I'm Augusta. I work in Mississippi to transform the health system there. My question is, where do public health professionals fit into all of this? So it's a general question, but any just like specific.
That's a delightful question.
It's a great question, and what is wonderful is that HHS is starting to publish more scholarly publications related to public health, and requiring all of the public health researchers who get federal funding to release their data sets as well. So there's the data sets that we collect that we're releasing, but there's also all of the data sets that researchers in public health are collecting, that it's now going to be required, this is going to be phased in, that when they submit their paper, they also submit their data set. And so that's one way that if you're a public health data geek, then that is, I think, going to be yet another wave of really useful data that's coming.
One of the most interesting conversations I've ever had about data with the government was when the FTC called us and said, we'd like to look at your data because it's easier to get it from you after pulling it out of the government from a FOIA request than it is for us to go over to HHS or CMS and get it. This open data stuff is really useful because it's actually a way for government to interdepartmentally communicate in a way that hasn't happened before. So you can actually solve a bunch of problems by using this open data. So please consider that as an option. I think this is a new pathway. It's not ideal, but the fact that it's a totally new angle, I think, matters. I think we're out of time.
So we take one more question, then
One
we're
more
out of
question.
time.
Good afternoon, ma'am and sir. My name is Sinaji Tahan. I'm from the Federal Healthcare Center in North Chicago. We're the DoD VA integrated facility in the country, the only one currently. My question is regarding, you obviously set up some great work through the Health and Human Services for cross-functionality. What do you see as the future of kind of doing some cross-functionality work throughout the other departments and the federal entity? And in addition, DoD just kind of moved towards getting our new electronic healthcare record system. And how do you think that will help to kind of alleviate some of the issues with our federal government kind of being behind the trend with healthcare?
So I'll just say that I'm practically a diagnosed irrational optimist. So I really believe that the more that we are able to create this state where we have data liquidity, it has to flow. And so I love that there is, a place where DoD and VA are integrated. That should be national, just as it should be national, interoperability. But we happen to have somebody so do you want to say about the VA? You've worked in the VA.
No, I've coded a little bit on Vista, and actually I was going to say, the government's kind of interesting because you are in some ways behind commercial software, and in some ways you've always been ahead. And I think the reason you've always been ahead is your incentives have been aligned. And so things like Vista and the software at IHS and was it Alta, were good long before its time precisely because of the incentive alignment. I will say that as far as open data goes, since that's what I specifically care about, I see trying to get clinical data out of EHRs and making that open data as the new beachhead. I honestly don't know if I will have the privilege in my lifetime to think about opening anything else except claims data, because there is so much to do. But that's not where the real value is. And the notion that there is government systems available that have EHR data like yours, that I might be able to convince someone who's not you, because you don't have, it's not her department, but if I could convince someone in the government that they should have an open data policy, it would be an amazing fact to be able to say, what is the average blood pressure at every VA hospital in the country? Really simple data sets like that, there's no way that's ever going to be tied back to a patient. It's not going to be tied back to a provider. There's a lot of good work that can be done there, and I have high hopes for that. I hope I'm going to be one of the people who gets to participate in that. I don't. There's a lot of work though.
And I'll close by saying that we're 7 years into this data liberation movement at HHS and really across the government. And what we've seen is that there is so much value being created because of open data that I think it's just going to continue to open new beachheads, new vistas, and to coin a phrase. And the idea that we all want to learn more about this system as it changes, whether it's going to be the individual patient who gets access to their data, whether it's a healthcare system and creating the interoperability there, or whether it's the whole system. Because we in the government need to understand how things are changing all across the country. And that's really what we've been able to do thanks to open data. So thank you guys so much.
Thank you so much. This was precisely as much fun as I thought it was going to be. So that was nice. Thank you guys.
Thank you.